Who to record?
आपकी रिकॉर्ड नहीं हो रही.
Bismillahirrahmanirrahim. Today's
It's
message.
okay. Please start your presentation.
Treatment without prevention is simply unsustainable. That's today's message. And my topic of presentation is today is rabies. WHO message is our time to act is now. Save the life, share the message. This is the WHO message, and the Rabies World Health Day is celebrated on September 28th of every year. Today's learning outline would be the introduction of rabies, epidemiological determinants, clinical manifestations, levels of prevention, and recent advances. We will talk about rabies, and by the end of this presentation, we'll be able to understand about the elements of animal rabies control, element of human rabies prevention, basic issues on the rabies prevention and control, and national and global updates. Let's start with the introduction. You know, rabies is a highly fatal disease of CNS caused by Lyssa virus type 1. It's a zoonotic disease of warm-blooded animal and is transmitted by the bites of rabid animal. Incubation period is long and variable with short with a variability. No, there is no treatment, and only prevention is the treatment available. Just have to minimize this window here. Okay, that's good. Let's start with the epidemiology of the rabies. First, the agent, the size is 180 into 75 nanometer, has a lipoprotein envelope, knob-like spikes and glycoprotein G is there, and M protein layer also around it. Genomes unsegmented and linear negative sense RNA is there. Surface spikes composed of glycoprotein G. It produces pathogenicity by binding to acetylcholine receptors in the neural tissue, and it stimulates T lymphocyte cytotoxic effect, and also have heme agglutinating activity. Here's a picture of that virus. You see it's a bullet-shaped virus having core RNA, having ribonucleoprotein complex, phospholipoprotein, large protein, and nucleocapsid RNA. And the size is, you know, is a micro 80 into 170 nanometer. Let's talk about the types of the viruses. There are two types of rabies virus, street virus and fixed virus. Street virus are those which are recovered naturally from the cases of the rabies in the street. And the fixed virus is the virus which has short, fixed, and reproducible incubation period. While the source of street virus is naturally occurring virus from saliva or rabid animal or infected animal, while the fixed virus is prepared by repeating culture in brain of rabid animals, such as so that its incubation period is reduced and fixed. Street virus produces antibody, which are cardinal sign of the rabies pathogenicity. Once producer Dagri bodies in the, we will discuss in later part of the slide presentation. And the fixed virus doesn't form any Nagri bodies in the brain. The street virus incubation period is longer, while the incubation period of the fixed virus is very short, few days, while the street virus has 20 to 60 days. Street virus is pathogenic for all the mammals, while the pathogenicity can be produced in the fixed virus under certain conditions. Street virus cannot be used for preparation of vaccine, while the fixed virus is only used for the preparation of anti-rabies vaccine. Source of infection, let's talk about the main source of infection is saliva of the rabid animal. Dogs get viruses in saliva 3 to 4 days before clinical symptoms. As far as the host factor is concerned, all warm-blooded animal, including man, rabies in man is dead and infection, you know, and the people at risk are the lab workers, veterinarian, dog handlers, and hunters. WHO target zero is to end the rabies by 2030, 0 by 30 is the message, and And you know, the rabies is 100% vaccine preventable disease. 28th September is the World Health Day. The mode of transmission, there are various types of transmission route, the animal bite, leaks, aerosol also, and the person to person, which is, although is very rare, but it does happen in some cases. Incubation period, it normally 3 to 8 weeks, maybe as short as 4 days, or maybe as long as years, depends on various factors like site of the bite, severity of the bite, number of wounds, amount of virus injected, species of the biting, and animal protection provided by the clothing and treatment taken. All these factors depend on the duration of the incubation period. Once infection sets in, these are the routes from where the virus reaches to the eventual site. First, there is a centripetal transmission from infection site to nervous system, and from nervous system to the periphery, to the peripheral nerve. So we see first from infected wound site multiplies locally to a mycocyte for weeks or months, and then travels to CNS. And from CNS, it moves out through the peripheral nerves and cranial nerves, that is centrifugal transmissions, and then affects the salivary glands mainly, and skin, muscles, gut, and other parts may also be affected. And saliva infects for several days, up to 2 weeks before signs symptoms appear and eventually lead to death. This is the histological picture of the Nagri bodies in the brain, which are cardinal sign of diagnosis of the rabies. Symptoms are, as far as the symptoms of the case of the rabies are concerned, this may start with the headache, fever, sore throat, or nervousness, confusion, pain, tingling, hallucination, hydrophobia, and paralysis, coma, and death. As far as clinical findings are concerned, bizarre behavior, agitation, seizure, difficulty in drinking, patient will be able to eat the solid food, is afraid of water, which is called hydrophobia. Spasmopharynx produce choking and death in 1 to 6 days due to respiratory failure and respiratory arrest. That is some, very rarely, some may survive there. Stages of rabies infection, there are, here's the demarcation between the non-specific prodromal phase, acute neurological encephalitis, coma, and death. As far as diagnosis is concerned, for diagnosis purposes, we label the case which has presented with acute neurological symptom dominated by form of hyperactivity, paralytic signs of progress, which progresses towards coma, and that's usually by cardiac or respiratory failure within 7 to 10 days. Suspected case is that which is compatible with clinical case finding, and probable case is that probable case is a suspected case plus a reliable history of contact with suspected, probable, or confirmed case, while the confirmed case is one that has been confirmed by the laboratory finding. Here are the few facts about the rabies vaccine. Is a preventable disease. I talked about it. Prevalent in more than 150 countries. Dogs are the main source of human rabies death, contributing about 99% of rabies transmission to human. Infection causes to thousands of deaths every year, particularly in Asia and Africa. Globally, the burden, in the cost of rabies is 8.6 billion per year. 40% people suspected, 40% people bitten by the suspect rabid animal are children under 15 years. Immediate wound washing with soap, water, or the contact of suspected rabies is crucial and can save the life. Engagement of multiple sectors and One Health collaboration, including community education, awareness programs, and vaccination programs, are critical. WHO leads the collective United Against Rabies to drive progress towards zero human death from dog-mediated rabies by 2030. Let's talk about the prevention of rabies. It has two components: animal rabies control and human rabies control. As far as animal rabies control is concerned, we have two components: primary prevention measure and prevention measures used to prevent the disease at the source. While the human rabies prevention, we have the secondary preventive measures. As far as animal rabies control is concerned, The animal strategies, these include mass vaccination of the dogs, movement restriction, confinement, or guaranteeing the control of stray dogs. First, we talk about the vaccination of dog. Animal pre-exposure vaccination, for that matter, is suggested for effective control. At least 75 to 80% of the population should be vaccinated of dogs and should be done at regular basis. Restriction of movement, as far as the recommended period is isolation and observation is 10 days for dogs and cat, while animal quarantine is 6 months. Animal exposed for those who are exposed and previously vaccinated also. Euthanasia of unvaccinated animal if exposed and another, method of control there. Measures for stray dogs control, the various measures are suggested here: create responsible dog ownership among the community, dog registration and identification, which include mandatory rabies vaccination and traceability, environmental control, and which is excluding dogs from the source of the food, and human dog population management, which is animal birth control. Euthanasia is also mean that act of inducing death in a humane manner, and control of the dog movement. The leash laws and roaming restrictions. As far as the human rabies prevention is concerned, there are three measures. Of first, what we can do is avoiding exposure, and second is pre-exposure prophylaxis, and third is a post-exposure prophylaxis. As far as avoiding exposure concerned, one should avoid contact with the unknown animal, nursing rabid human animal with care, while pre-exposure vaccine is recommended for anyone who is at continual, frequent, and increased risk for exposure to rabies virus, such as laboratory worker, veterinarian, and animal handlers, while post-exposure vaccine is administered after an exposure. A bit about vaccine itself. Since 1984, strongly has recommended discontinuation of production or use of nerve tissue vaccine and has been replaced by the cell culture embryonic egg-based rabies vaccine. Nerve tissue vaccine has had more adverse reaction and frequently are less immunogenic than cell culture vaccine. WHO recommends only cell culture vaccines, and since 1960, cell culture vaccine has been administered to millions of people, both in pre-exposure and post-exposure. Cell culture vaccine should imply the recommended potency for the vaccine is to equal or more than 2.5 international unit per dose of intramuscular injection, and the vial is of 0.5 or 1 ml after reconstitution, depending on the type of the vaccine. Rabies vaccine is currently available only in a single dose and do not contain any preservatives. Little more about the vaccine. Cell culture vaccine is administered by intradermal or intramuscular route, and efficacy of intradermal route is as equal as the intradermal vaccine is as good as the intramuscular, and for that matter, you can say that intradermal vaccine is more, cost effective because the lesser amount of the vaccine is used. The concentration of antigen presenting in the cell in the dermis is responsible for strong immunogenic response to vaccine administered intradermally, despite the lower amount of antigen injected. Intradermal post-exposure vaccine regime uses at least 25% less vials than intramuscular post-exposure regimes. So a number of patients seen in the clinics increases. Intradermal regimes become increasingly cost-effective, using up to 85% less vaccine vials. Here are the two, the latest articles about the rabies, which I could find that on the internet. First is the WHO position paper, which was published in 2018, and it replaced the previous guidelines, which were published in 2010. And now, based on that, this position paper. The peoples are, explaining this and narrating their own stance of this position paper. And the second on your right is the other paper uh, written by the another person about explaining the position paper of rabies immunization 2018 updates. Let's talk about the administration of rabies vaccine. Both post-exposure and pre-exposure vaccine can be administered by either intradermal or intramuscular route. For all ages, all age group intradermal injections are the deltoid region, either anterolateral or supralateral region. Recommended dose for intramuscular is the deltoid area in the children equal or more than 2 years of age, and rabies vaccine should not be administered in the gluteal area intramuscularly. One intradermal dose is zero point 0.1 ml of vaccine, and one intramuscular dose is entire vial of vaccine, irrespective of vial size. We will discuss it in a bit detail here. First, we will discuss about the post-exposure prophylaxis. Post-exposure prophylaxis steps are there. All bite, wounds, scratches, and rabies virus exposure site should be attached to as soon as possible after exposure. Thorough washing, flushing of the wound for 15 minutes with the soap or detergent, copious amount of water where available, and a series of vaccine injections should be administered promptly after the exposure. Rabies immunoglobulin should also be administered for severe category 3 exposure. What are this category 3? We will discuss a bit later. Wounds that require suturing should also be sutured loosely only after immunoglobulin infiltrated into a wound. WHO recommends post-exposure vaccine for category 2 and 3. What are these categories? Category 1 is just touching on feeding animal legs on the intact skin, so we label is no exposure. And category 2 is nibbling of the uncovered skin, minor scratches or abrasion without bleeding. We label it as exposure. And category 3 is the single or multiple transdermal bites, scratches, contaminated mucous membrane or broken skin with saliva from the animal licks and exposure due to direct contact with the bed. We label it as severe exposure. WHO rabies exposure strategies are there. The intradermal post-exposure vaccine schedule are the cost and dose sparing and cost effectiveness increases with the number of patients seen in the clinic. If the repeated exposure occur in the 3 months of the completion of the post-exposure rabies, only wound treatment is required. Neither vaccine nor immunoglobulin are needed. And vaccine should a vaccine dose be delayed for any reason, the post-exposure schedule should be resumed, not restarted. Individuals with documented immunodeficiencies should be evaluated on a case-to-case study, on case-to-case basis, and receive a complete course of intradermal or intramuscular post-exposure vaccine, including immunoglobulin. Here is the table you can see for regime for various categories, category 1, 2, 3. You can see that for the category 1 in the immunological naive individual of all ages, when there is no exposure, no treatment. But in category 2 and 3, you can see we give that either intradermal or intramuscular rabies vaccine on different doses. But for category 2, we don't recommend immunoglobulin, but in category 3, we include rabies immunoglobulin along with the vaccination. While in a previously immunized individual group, there is a separate schedule for there. You can go through it, but I will discuss it in a bit later slide. So the summary of this is that if there is no exposure, no treatment, no reliable history, there is nothing to do. We don't need anything to do. While there is in category 2, nibbling or uncovered skin, minor scratches, abrasion are there, we do the wound management and we give the anti-rabies vaccine. While if there is severe exposure, single, multiple transdermal bites are there, contamination of mucous membrane with saliva, then we do the wound management, rabies immunoglobulin, and along with the anti-rabies vaccine. Rabies immunoglobulins are administered as soon as after initiation of post-exposure vaccine and not beyond the 7 days after the first dose of the vaccine. There are two types of immunoglobulin, E-mine and type and human type. Both are as effective as the other, and there is no chance of, the nowadays are highly, even the E-mine immunoglobulin are highly purified, and then there is no chances of any anaphylaxis, and WHO recommends that it's unnecessary to do any skid testing before administration of them. To confirm the maximum public health benefit, WHO recommends that the maximum dose for immunoglobulin of human is 20 international unit, and while the E-mine is a bit larger dose, 40 international unit are administered. Infiltration is maximum into the wound, remaining is calculated dose is not needed against the previous guidelines. In the past, we have been injecting the half of the vaccine around the wound and half to the muscles, and now the recommendation is there is no need to injecting intramuscularly, but only infiltration around the wound. Pre-exposure vaccine prophylaxis, we do it for several days, and is administration of several doses of rabies vaccine before exposure to rabies virus. And pre-exposure recommendation is high to the people who are at high risk due to their occupation, and should be considered in the subpopulation living in remote rabies endemic area where the dog bite incidence is more than 5 years, or vampire and bat rabies is known to be present there. The immune response to subsequent rabies rabies vaccine boosters such as post-exposure prophylaxis when exposed can be recalled for very effectively, and even decades after the pre-exposure prophylaxis. Pre-exposure prophylaxis, we give 2 doses, intradermal or intramuscular site, 0 and 7 days, a routine pre-exposure booster or serology of neutralizing antibody titer is recommended if there is a high risk of antibody exposure remains there. Booster is only recommended there is after testing the antibody titer. Individual with recommended immunodeficiency should be evaluated on case-to-case basis and best receive intradermal intramuscular pre-exposure schedule, plus a third vaccine administered between 21 and 28 days. Additionally, in the event of exposure, a complete post-exposure prophylaxis course, including immunoglobulin, is recommended. Requirements are there, should be backed by the legal framework, by the government allocation of resources, expanded diagnostic services, surveillance systems, skilled manpower, collaboration among the stakeholder, and community education and participation is required for effective rabies control. These are the references for my presentation for today. Let's start with the MCQ. Which of the following is true about the rabies? You can read it first. It's the correct answer. What you said that?
A.
The correct answer is death have occurred post-transplant. It's D, because the corneal donation of the rabbit person have happened half here. But all of the above in a sense, the correct answer is the, anyhow, I will explain it later on. It's corneal transplant. In corneal transplant, the rabies, death from rabies have occurred. Rabies immunoglobulin Regarding immunoglobulin, you can read the four options.
C.
Anyone else? About rabies influence, B at least half should be infiltrated around the wound. That I have told you during this discussion. Which of the following is false regarding the vaccine?
C.
Yes, that's it. Blood cell vaccine can lead to ulceration if intradermally. It's false. A traveler comes to the clinic after getting 2 doses of vaccine 6 months ago, and next week he's traveling to endemic area for rabies. What should you do?
C.
Let's be give 1 dose of vaccine and assume he has good cover. Which of the following is false? Mandated
C.
D.
it's B. Post-exposure vaccine should be given via it's false via intradermal route. Post-exposure, eh, I have told you that it's given around the wound, and there's no need of another intramuscular intradermal. Rabies virus.
B.
B.
No, it's not. It's transmitted by aerosol secretions. The best public health here is
B.
vaccinate all. Rabies virus is passed through contact with
B. B.
soon after infection by
Within 6 hours.
2024. What should you do if the bitten by an animal?
B.
Oh, let's see.
Thank you very much. Please, I request everybody should mute their mics. Dr. Dawood, it is a wonderful presentation. The most important point about rabies is that if you are being scratched, bitten, or unsure about the exposure, you must get the vaccine because the rabies is 100% preventable. But once there are the clinical features, everybody should be clear that there is 100% case fatality rate after the onset of clinical symptoms and signs in rabies. I have very important question from you, Dr. Daud. You have talked about very important pathogenesis of rabies. My question is, what is retrograde axonal transport? Because we all know that it is the peripheral nervous system that causes the travel of the virus to the central nervous system. So what is the retrograde axonal transport relevant to rabies?
Uh, as I discussed in my presentation, first there is a transmission towards the central nervous system, and from the central nervous system towards the periphery, centripetal and centrifugal transmission. From the CNS to the peripheral nerve, including saliva, from where the infectious, the virus goes to the other animal or the other person, other mammals.
It is very important to understand very important pathogenesis of rabies because it is quite different from the other viruses. It consisted of axonal transport, as axonal transport is also called exoplasmic transport. So the movement is towards the cell body. Actually, it is from the axons towards the cell body. Normally, what is the normal transport is from the cell body to axons. But rabies virus, it is one of the example where the transport is and the movement is from these axons towards the cell body. So that is why it is called retrograde axonal transport. Another important point is about the clinical features. You have discussed very important clinical features. However, there are some striking clinical features that are very peculiar about rabies. And one is the hypersalivation and hydrophobia. And would you please explain these two clinical features in more detail?
Madam, once this sort of symptom sets in, there is a, I mean, the person is able to swallow the solid food, but he is afraid of, I mean, choking. That's why he avoids drink any liquid. And by even by seeing water, he goes into, I mean, fits, and there may be a spasm of respiratory system or respiratory muscles. Even the sight of the water.
Very rightly said. Very rightly. Right. Very right. Because there is so much salivation that it starts coming out of the mouth and even dribbling on the clothes of the patient. And hypersalivation is very obvious feature. Similarly, the hydrophobia, if a glass of water or even if the bottle of water can lead to severe spasm in the laryngeal muscles. And there is a hydrophobia, means fear of water. And they can swallow the solid food, but whenever there is some water or juices or something that is containing water, it is causing severe type of fear and laryngospasm that is associated with it. And it is again a very striking clinical feature of rabies. Another important thing is my last perhaps question is, what is the